Welcome to Your Health this Wednesday, and today we look at what has been happening in the health sector this year. And 2017 has been a difficult year for the Kenyan public health sector. Kenyans witnessed industrial actions by three of the main cadres in health, that is the doctors, nurses and clinical officers. Many opined that these strikes were just but the symptoms of a more deep-seated problem that, if not addressed conclusively, may arise again and the cycle of unrest restarted. The Constitution of Kenya 2010 devolved some functions in the health sector and identifies health as a right. Are Kenyans anywhere near attaining the best healthcare as is guaranteed by the Constitution? Are the healthcare providers working towards making this a reality for many? That is our discussion this morning on Your Health. And with me is a panel of three. I have Daniel Yumbia, who is the Chief Executive Officer of the Kenya Medical Practitioners and Dentists Board. I have Dr. Njoki Ngumi, who is a healthcare giver, and Mr. Thaddeus Mayaka, who is the Chairman of the Nursing Council of Kenya. Now, I'll start with you, Mr. Yumbia. We've seen the many industrial actions. The doctors went on strike for 100 days. The nurses went on strike for 5 months. In between, you had clinical officers on strike. Have we learned any lessons in 2017 because of all these industrial actions so that we don't repeat them in the years to come?
Thank you, Mercy. I think as the Medical Practitioners and Dentists Board, we were the first casualty in terms of the industrial unrest. As a board, we learned that besides the Constitution of Kenya 2010 giving Kenyans right to emergency treatment, the board is yet to put into place regulation that addresses the issue of emergency care. This vis-a-vis the time of industrial unrest. We're looking at a position where a patient is supposed to go and get emergency treatment, and then in a private facility, to put it right. Now, who pays for it? There's no fund which has been set aside. So you're telling a private investor that you must have equipment, you must have medicine, you must have personnel in place who will attend to emergency care. And then after they've given their services, they are not the government. So there must be funds set aside by both the national and the county governments to cater for emergency treatment. Number two, during the strike, as a country, we looked at, as a board, we looked at world over. I had discussions with the General Medical Council of London, of UK. This is a regulatory authority in London, in UK, and HPCSA in South Africa, and Australia, and the Federation of Medical State Boards of the US. And it looks like we have failed internationally to put regulation that addresses emergency care in times of unrest. Therefore, we expect the doctors not to abandon their patients when it is their time to demand for their rights. But we have not put in regulation which says during the time of unrest, the union should ensure that emergency care continues to function. As a board, we panicked at one point when the union went to KNH and they said that even KNH was going to come to a close. They were going to close the KNH, which was the only functional national government hospital. And they said that they were going to get the private sector joining the strike. And then we said, now this is going, and that's the time we called in a meeting. So as a board, we also realized that when the union gave a notice for the strike, we ignored. We slept on it. It looked like it was a joke. I mean, they would discuss, and we sat back and watched and waited for things to unfold.
Yes.
So we called them in when it was too late. And it was a question of moving from the union to the government, to the minister, to the DMS, and talking to the union. And sometimes we had a very fruitful, focused discussion with the union. Now, as a board, when we convened a meeting, we resolved that we should have engaged the union at the beginning. When they just said things are not going right, these are our demands. The first time of issuing a notice should have been the time of engagement.
Okay.
This is the time the board should have said, come sit down. Then we hear them, then we go to the next level. But the idea of waiting for things to go wrong, and then when they're at the peak is when you're looking for a discussion is tough.
Let me hear from the Nursing Council. Did we learn any lessons from the 5 months that the nurses were on strike, the 100 days that the doctors were on strike?
Yes, Dr. Mercy, we learned a lot. And I'll want to concur with what Mr. Yumbia said here. When the nurses gave a notice, the trade union, that there will be an industrial action of nurses, really the government and all arms of the government involved actually sat back, as Yumbia said, and waited to see what will happen. So one of the challenges that I saw from where I'm seated as a regulator is the proactiveness of the government, both national and county governments, and also the Minister of Labor, who should have actually taken this issue or this warning by the nurses and the doctors as serious as it is. What really is not agreeing well with us as a regulator is that from where I'm seated, we know that the health service delivery, the Minister of Health is essential, right? Because we are giving critical services to the Kenyans. When it comes to industrial action, we are talking about life and death. We are talking of the health of the people. And this one is enshrined in the Constitution 2010 Kenya. Now we have the health sector, which is also actually trying to address some of these issues. So what I'm saying here is that because, like the Nursing Council of Kenya, I can actually say without missing my words, I tried to get hold of the chairman of the Council of Governors. I tried to get hold of the Cabinet Secretary, the Minister of Health, so that I could advise as a regulator, because the impact of an industrial action normally is not something to really joke around with.
Okay.
So what I'm saying here is that as the relevant arms of the government, from regulation, employer, professional associations, and the trade unions, let us engage in advance on matters affecting the welfare of our workforce in the health sector, and also matters affecting health service delivery, because our systems have got challenges, right? And how can we address these challenges in hand so that we do not affect the service delivery of what? Of the citizens of Kenya.
Okay. Dr. Njoki?
I mean, I think we've learned an incredible amount of, we've gained some wisdom, and hopefully it goes forward to help us solve problems at a point where we are not in crisis mode, because also solving problems during crisis mode becomes very difficult. I think I can kind of frame it in 3 different ways. One is that we have been approaching health service issues as an either-or, and it means either the well-being of the people of Kenya or the well-being of the health service providers of Kenya, when we should be doing a both-and model. We cannot have happy service providers giving bad service. It's not going to happen. At the same time, the people of Kenya are not going to receive poor quality services if the service providers are unhappy. So we need to reach a place where, first of all, it becomes a national issue, not just the issue of the health service providers, but an issue for all people when health service providers go on strike. The people of Kenya cannot afford to continue just watching health service providers strike and not participating in the conversation, participating in the strike, and kind of waiting it out. It's not going to happen when we wait it out. And that's what Mr. Yumbia just said, that it's very easy to just kind of watch a thing happening and then only start reacting when the crisis reaches a terrible place. There's a number of Kenyans who lost essential health services in this period of time, these periods of time during when the doctors were on strike, when the nurses were on strike. All of these things are essential. The second thing we've learned is that it's been very difficult so far. Hopefully this changes in the future. It's been very difficult so far for health service cadres to work in concert. This strike would have been solved in minutes if the doctors and the nurses and the clinical officers had gone on strike at the same time. It would have been catastrophic. It would have been historical, but it would have been solved the same week, the same day. But now when we see it as, let's solve the doctors' problems, and the minute I saw let's solve the doctors' problems, I said this is bad, because what we are telling the other health service cadres is that their problems don't really matter. So they're going to go on strike next. And it was like a countdown. When the doctors were done, the nurses went on strike. When the nurses' strike looked like it was starting to end, the clinical officers went on strike. There's also the allied health workers, who include medical technologists, people who work in X-rays, all sorts of things, all of the people who support staff, even the people who clean in hospitals are very, very important to the working of health service provision. Even when we talk about the people who work in hospitals, we don't even consider community health workers and people who give primary health care out there. So there's many things to consider, including having more united conversations about the processes of health, human resource optimization. We've learned that some elements of health probably should not have been devolved. And we saw, especially in the conversation around the nurses, the governors playing fast and loose, where some governors are saying, you guys come back. Other governors are saying, we are firing you all. And that now made it very difficult for the nurses to work together as one group of people. So that's another thing that we need to deal with. We've reached a point in our devolution where we can say some of these things probably should not have been devolved quite yet, or probably should not be devolved at all. Maybe human resources, as far as health is concerned, shouldn't be devolved, but other functions of health can be devolved. So we've reached a place where we can become a little more nuanced and disaggregate the idea of what devolving a sector means. Okay. The other thing we need to consider, and this is my final point, is that this was an odd year for Kenya. We were all already in this kind of electoral milieu of crisis and tension. So of course it was going to be a bad year for labor problems. And we've seen labor problems not just in healthcare, but across the board. And what we've realized is that the Kenyan state and Kenyan society are not very kind about the issues that their labor force are facing. And this is the employed labor force. So can you imagine what is happening with people who work in the informal sector, or indeed with people who are not employed at all? We've kind of swallowed this idea that being employed is better than not being employed. And so the minute you're employed, you should be grateful regardless of the shenanigans that you have to go through. What we've discovered with health, and probably can be true of a number of other sectors, is that there's deep rot, there's issues we've not sorted out, there's all sorts of mambo jumbo that needs to kind of be teased out and solved step by step in a very deliberate way, with high political will and with consistent communication and debate with the people of Kenya. And so figuring this out, and I guess it will be easier during non-electoral years, is going to be key if we're going to move forward in treating our health labor force and our wider labor force better. Okay,
all three of you have raised issues on engaging as a health sector, all cadres to engage and work together. And the Health Act 2017 was passed, and probably one of the issues that were seen in the Health Act was to bring the human resource aspects together. And we have the Kenya Health Human Resource Advisory Council, which primarily is involved in the human resource aspect, posting of interns, specialists, and whatnot, and the Kenya Health Professions Oversight Authority, which brings the regulatory bodies together. Mr. Yumbia, will these two bodies in the Health Act be a cure, or do they still have issues within themselves?
Yeah, Mercy, I think let's look at the Constitution. And I've always challenged doctors and asked them, when the Kenya Constitution 2010 was being made or being revised, where were they? The doctors tell me they were busy in theater, they were busy in clinics, seeing patients, because that's where we missed the whole thing. And I've been to the Health Parliamentary Committee, or Parliamentary Committee on Health, and I told them that as much as the union woke up a bit late, this problem of Health Service Commission being entrenched in our constitution would have sorted out the issues Mayaka and Joki are trying to raise. Why do I say this? Because when you look at the Teacher Service Commission, it addresses the P1, the approved teacher, the diploma teacher, the graduate, the master's graduate, teachers in colleges, teachers in primary and secondary schools. Mm-hmm. If that commission was established as per the Constitution, problems for human resource in the health sector would have been sorted out. Mm-hmm. Now, the Health Services Advisory is just a stopgap. Mm-hmm. I think we discussed with the parliamentarians, it looked like until the Constitution is amended, the Health Service Commission cannot be enacted. And therefore, this is the starting point. Now, the Health Services Advisory Committee or Board will really try to address the issues at certain levels. But the autonomy of the Health Service Commission, which should be anchored in the Constitution, is something that I don't want the health workers to stop agitating for. If politicians want to establish certain things in the Constitution, health workers better wake up, and at that time, you come out and say, this is what we want. That's that. Point number 2 is about the Health Professions Oversight Authority. Yes. I have been involved in the subcommittee that was dealing with the establishment of an oversight authority for boards and councils. I agree, as per the Health Act 2017, the Oversight Health Authority
Kenya Health Professions Oversight Authority
should be made to operate or operationalized. However, it needs some amendment, even as it starts to work. We did a benchmarking tour of the Health Professions Authority of South Africa. This is the mother, or this is where we are borrowed. And the Health Professions Authority, Health Professions Council of South Africa, brings together about 27 cadres, including the paramedics. In fact, most of our patients who are rescued from accidents, scenes of accident, end up dying while they should not have died, because we have nobody to regulate the people who rescue accident victims. In South Africa, that cadre is regulated by HPCSA. HPCSA brings all the boards and councils together, except a few. And what they do is that the boards and councils report to this oversight authority. I need to be regulated, not by the ministry, but by a body that I account to. We sit as boards and councils quarterly in an amorphous situation, which is brought together by the Director of Medical Services. We envisage this body to bring us together legally, where the Nursing Council will come and say, during this particular period of time, this is what we have done, and these are our challenges, and then we say, and how can we move forward? What are the areas that we need to work together? When this bill went to Parliament, we had proposed the composition. I have a problem with its composition. The composition was that all the 9 health regulatory boards were members. That gives 9. Let me explain that point. It's key and very dear.
To take a break. Just briefly.
It's dear to me. This bill brings all the boards and councils together, plus any other stakeholder who is required to be put there. When it went for stakeholder consultation, we agreed as boards and councils, even the professional associations should be given slots. And we said we can even give them 2 or 3. For us, we are not worried about the numbers. But now we are told Mwongozo talks of 12. Now when they go to Mwongozo and they talk of 12, the act, as it is now, says only 2 health regulatory authorities shall be represented there. I'm looking at a situation where the Nursing Council will say they need their person there. Exactly. The clinical officers will say they need. Then the doctors will say, of course, it's automatic. We are the leaders in healthcare regulation, so we must sit there. And then now the pharmacists will say, all right, without medicine, how do you work? So I don't know why at some point people decided to change. Our idea was not to go to the mwongozo. We are looking at a hybrid situation which is going to bring cure to our problems. Now, when you say you put the AG is represented, and then you say the consumer, very good, the Council of Governors, very good, you limit the numbers. The number of two health regulators is the key. What are the functions of this board, this body? And we agreed. We said one is joint inspections. So when you carry joint inspections with the two boards who are members, what are the results?
Okay.
Number two, addressing cases of medical malpractice that cut across. You want to try a nurse, and the nurse is not even a member. A clinical officer is not even a member. A doctor is not even a member. How do you handle that? So what we have agreed with the ministry, we are consulting. We have now established a committee to look at the way of making this operation, and we are saying, let's come together and see how we can do this. And we introduce a small amendment of co-option. If you co-opt, and you get power to co-opt, this thing moves out, and we go and achieve. Finally, you're talking of so many problems in the health sector, and I think we have made a lot of progress. The modern equipment that is available in hospitals, the kind of investment that the government has done in the leased equipment is quite a lot. Health workers are also devoted. Don't always come and cry. The health sector is scrabbling. We have not done much. I look at the interns, their devotion. I look at the doctors who are training. I look at the output. I look at the private sector. In fact, private sector now is struggling to get on their footing to retain interns in their facilities, because the government is paying interns higher than the private sector.
Yes.
And that, to me, is a plus to the government.
Okay, I know you have a lot to react on, but I want us to take a break because we have to release Mr. Yumbia. He has another engagement, but thank you very much for your contribution this morning. We'd have loved to continue having you because, well, there's a lot to discuss. So after the break, I'll take your comments, Dr. Njoki and Mayaka. So we take a short break, after which, when we come back, we look at the Health Act and the two bodies that are looking into the human resource aspects of health.